Hi everyone. The technology I chose here is Remote Monitored Intensive Care Unit, which is also known as eICU. The reason I chose this technology is because over the past several years, a lot of pressure has been on the intensive care units due to the drop in care quality and the increasing cost spent to care for ICU patients. The ICU suffer severe shortage of intensivists, which is the healthcare providers trained in intensive care medicine, especially in the rural areas. The data also shows that there are fewer than 6,000 intensivists practicing in the US, and only 29% of the hospitals with ICUs nationwide currently meet the leapfrog criteria for quality. The leapfrog criteria is a guideline to rate hospitals based on outcomes and patient volume for selected high-risk procedures, as well as staffing levels and other safety measures. eICU combines clinical expertise, softwares, and proven process to improve care quality in ICUs. It's a centralized remote command center with the applications of telemedicine technology, which allows intensivists and nurses to monitor multiple ICUs. The software tools can be divided into 4 components. The first one is Smart Alerts. This software evaluates trend in patient physiologic and laboratory data. They have alert tone, which indicates when a patient is straying out of bound. This will allow earlier interventions of physicians. The second component is the clinical documentations. This program has tools to capture all patients' data in one place, so it's easier for documentation, reporting, and reference. It will also improve assessment and treatment as the profile of the patient is accessible by all the professional care teams for reference. Another component is the online decision support. They have this tool called the Source. It's a tool that allows clinicians to access online evidence-based care guidelines. This guideline is regularly updated by international panel of experts. And the last component is the outcomes tracking, which includes a tool called Daily Management Tool that records up-to-date clinical status of all ICU patients to support evidence-based care. They also have another software called eCare Manager software. It's a sophisticated software that enables integration between ICU and eICU care providers while supporting patient information flow during hands-off points like shift change or during the transfer to different locations. It's a dashboard user interface for fast clinical analysis and review of tasks. The performance and usefulness of eICU presented here are based on 8 scientific evaluations on the impacts of eICU program conducted by clinicians of 5 different health systems in the US. This program was shown to improve ICU mortality rate and the length of stay. Avera Health reported on the impact of eICU and ICU integration, demonstrated a 60% improvement in the severity adjusted ICU mortality and a 35% improvement in the severity adjusted ICU length of stay. There's also improved effectiveness of rapid response team. Parkview Health evaluated the effects of their eICU intensivists participating virtually with their rapid response team. The result was a 26% reduction in non-ICU cardiac arrest and impressive nurse satisfaction. Its impact on critical care training evaluated by Memorial Hermann in conjunction with the University of Texas Medical School and St. Luke's Health System shows that all critical care fellows surveyed believe that eICU program saves lives. 14 of 16 fellows wanted to work in hospital that uses the eICU program. 13 of 16 indicated that their beliefs that eICU program reduces malpractice exposure. The University of Pennsylvania documented a 29% increase in professional fee billing for critical care as a result of more robust physician documentation associated with the use of eICU. However, there are several barriers to overcome in eICU programs. Poor interoperability between the eICU software and the hospital's enterprise-wide IT system created barriers to using eICU in full extent. Although vital signs from bedside monitors and electronic laboratory data could be imported into eICU system, other data such as volume of intravenous fluids administered and ventilator setting could not. This also means that some smart alerts were not functional, for example for drug interactions or mechanical ventilator regulation problems. Although eICU is thought to improve quality, which might reduce costs through reduced complication rates and length of stay, it was difficult to isolate the impact of eICU from the effects of other quality improvement initiatives implemented concurrently. Some non-eICU hospitals have preference for on-site staff. They pointed the need to maintain on-site physicians 24/7 to perform procedures and interactions with families even though with eICU. Some of them questions about the return on investment. eICU needs huge upfront and ongoing operating costs. So far, there's no third-party reimbursement for professional service. The issue of whether they get a return of their investment depends on the structure of their unit before they begin. They may not gain much if their complication rate is already low. I think that scientific evidence continues to emerge that eICU does improve the quality of care in ICU and physician satisfaction. Although there are rooms for improvement of some shortcomings of eICU program, I believe wide adoptions of this technology by hospitals across nations will be a great benefit for both hospitals and patients. Thank you.